Namaskar, dosto. Good afternoon and welcome to yet another interesting session. Today we have this interesting session arranged by Shield Pharmacy. And thank you, Shield, for arranging such wonderful and interesting sessions. We do talk a lot about things related to preconceptional risk, but at times we are just clueless what to do, how to proceed further, and the risk factors involved in such cases, are they really real? Could it be possible for us to deal with such factors, or some fear is already there that what happened if I conceive? Could it be possible for me to have smooth pregnancy or not? So lot many issues, and what happens after childbirth, before managing the pregnancy, or management during the pregnancy. So this is a wide topic. We can say that we can incorporate many pointers in this, but today I would really love to talk about this topic concerning autoimmune and metabolic disorders. You can say that these two topics are my favorite. And to discuss these whole issues, these whole concepts, and to discuss this whole beautiful topic, interesting topic, we have Dr. Revathi with us. So, viewers, please start pouring your comments, start pouring your questions. I know autoimmune is a thing that worried us. Autoimmune is a new concept, but it impacts us before pregnancy, during pregnancy, after pregnancy. How to deal with it? Could it be possible for us to deal with it effectively? This is more important. So let's talk about this and let's invite Dr. Revathi. Good afternoon, ma'am. Namaskar.
Good afternoon, Purnima. Thank you so much for this opportunity. Thank you so much, Shield
Thank
Connect.
Thank you, ma'am. So, viewers, today we have Dr. Revathi S. Rajan with us. She's a chief consultant maternal fetal medicine. Please note down, maternal fetal medicine is a very interesting branch to study and know about. And she is a managing director of Mirror Health Bangalore. So, Bangalore members, please take a look and do visit Dr. Revathi if you have issues, you have medical concerns related to this. Dr. Revathi has more than 13 years of experience in treating high risk pregnancies. It's not that every time we talk about IVF, IUI, we do talk about natural conception, and natural conceptions do have high risk thing associated with it. So today we are going to discuss this with Dr. Revathi, as she has 13 years plus experience in this. She has treated many complicated cases, and interestingly, she has made those cases easy for the women who are seeking pregnancy and successful childbirth. Dr. Revathi has many publications in Indian and international, and she's also educating many doctors who had the special interest in this medicine field, we can say. And very important thing about Dr. Revathi, that she is making things easier for the women who are dealing with hypertensions. Hypertensions, really, it's a bad thing, we all know, but how to control it, how to manage it. So Dr. Revathi is doing special studies in this, and she is dealing with lot number of women who are into this hypertension, because as we all know, pregnancy rate is going up, 35 plus age, sorry, pregnancy age is going up, 35 plus, and yes, hypertension, stress, everything is adding up. So today we are going to discuss many things with you, Dr. Revathi. But first, to start with the session with main topic, preconceptional risk modulation. How you could elaborate this topic to our viewers, ma'am?
Thank you so much, Purnima. And I think we're talking about one of the most interesting and relevant topics, in today's scenario, because getting pregnant is a very important thing in anybody's life. I would say it's a joint responsibility of the couple. And nowadays, with so many complications, people are getting married late. There's a lot of career stress that is happening, lifestyle issues. So we would definitely don't want to leave pregnancy by chance. We would definitely want to make sure that we have a planned pregnancy so that we know that it is the right time for the woman to decide about conceiving. So this ultimately, this whole thing about preconceptional counseling is about, you know, identifying those factors which could probably lead to complications in either conception or after conception, that is during pregnancy. So it is a myth that, only women who've had, say, previous abortions or who've had a previous bad obstetric history, just like some baby, dying inside the uterus, or having a small baby, or having a baby with difficult milestones, or those with prolonged period of infertility, should only consult a specialist. That is a myth. What I feel is everything should be very programmed, and everything should happen by choice. So I in fact welcome each and every couple out there, to plan a pregnancy and do the basic evaluation, which we are going to elaborate in our futuristic discussions, and also make sure that they are at the right time to conceive. So this is the whole idea. And by doing this, what are the benefits? We can identify those medical and surgical risk factors, if any, which can lead to bad outcomes. So we don't want any woman to conceive at the wrong time and end up with an abortion, or any woman who's planning a conception, not to have a take home baby. So we would identify, spend that special time, because see, all factors, like for instance, it could be a TSH level, or it could be a blood sugar level, or it could be so many other factors which may not be the normal rates outside pregnancy, or the normal levels, the normal levels outside pregnancy may not be similar to those levels prior to conception. So this only a doctor can help you. So in my future discussions, I will also touch upon these, because this discussion is going to revolve around metabolic as well as autoimmune problems. So this kind of evaluation will probably throw light as to how to correct them if in case they are abnormal. We wouldn't say that you have a particular disease. We would just say that there is a disorder which could be corrected, and then put on, the woman can be on prenatal vitamins and make sure that her nutritional status is good, she's not anemic, and and even the husband can also make sure that his metabolic problems are under control, if any, and then proceed forward for a pregnancy, and that is very, very important.
So rightly said, Dr. Revathi, we really need to touch these topics. And let's start with this wide term, autoimmune. This is we can say that very common topic nowadays. And if I am getting calls from, say, 20 people in a day, so I can say that 15 are discussing this thing. So what exactly is this autoimmune? Because I think year or 2 year back we never discussed this topic, what is exactly autoimmune. We just know that she's a diabetic patient, she has thyroid issues, but now we have this full term related to autoimmune. So what exactly is this, and is this really some scary thing that we should manage on time?
Yeah. Correct, Purnima. This autoimmunity sounds very sophisticated. People are scared when we take out that term. But what you have to understand is, let me put it in very simple terms. Suppose somebody has an infection. Say somebody catches a common cold or fever. So what does the body do? The body will definitely, the defense mechanism of the body gets activated so that the antibodies are produced, so that whatever has been responsible for this fever or cold is countered, and the person recovers. All right. So this is basically how the immune mechanism works, how our defense mechanism works. But sometimes it can happen that there is an exaggerated trigger. That means there is some insult in the body. It could be a viral infection, especially in certain organs. Like, for instance, let me give you an example of the thyroid gland. There can be some viral infection, which we call, if I have to say Hashimoto's thyroiditis. So what happens here is there is some exaggerated infection which has affected the thyroid, And this thyroid starts producing some kind of antibodies, and this could be slightly exaggerated than the usual. So, after the condition has passed, these antibodies still continue to remain in the body, may be localized to particular organ systems like the thyroid, which is pretty common. And this can actually cause an exaggerated dysfunction. That means, the thyroid gland gets destroyed, and you might have, whenever there is a disturbance in thyroid function, obviously your TSH levels as well as the thyroxine levels can fluctuate. So
Right.
this can have an impact on conception, especially the thyroid gland. We have identified that there is an antibody called the thyroid peroxidase antibody, which is pretty common. I myself have done a study in 2015, which is published, where I looked at all those women who presented to me with hypothyroidism. And I found that, especially, we call there is an entity called subclinical hypothyroidism. That is, see, generally the levels are normal up to 5.5 microinternational units of TSH. But for pregnancy, we expect a level of less than 2.5. So any woman who's had a level of 2.5 to 5 can have a challenge to conceive. And these women can have TPO antibody positivity. That is, it could be an
Right. Right.
autoimmune trigger generated thyroid dysfunction. So what do
Right.
we do? So we have to identify that and immunomodulate them. That means, see, what happens is whenever there is autoimmunity, the
Hmm.
body recognizes the baby as non self. It recognizes it as a graft, like a foreign body, and
Foreign body.
starts
Right.
producing an antibody. That's why we use the term allograft. It has a little bit of the mother, it has a little bit of the father, but the body calls it foreign. So, what does the body do? The body produces antibodies and tries to get it out. So we have to make the body understand that it is self, and
Hmm.
immunomodulate them so that we get down that whatever is the bad immunity, and increase the acceptance of the fetal allograft. That is why people are presenting with, secondary infertility, they're having abortions, they're having difficult pregnancy problems. So I'm not saying this is the only factor, Purnima, but this is
Hmm.
something that which was not probably looked at previously, and now we are actually trying to look at it more
Right.
seriously and trying to find solutions.
So, Dr. Revathi, one thing, so we can say that recurrent miscarriages could be associated with this autoimmune thing.
Yes,
Okay.
yes, it could be. And Purnima, it could not be just that. There'll be
Hmm.
multiple factors. We've
Right. Right.
seen that a person who's autoimmune can be diabetic. They can also be having a clotting abnormality, and as well present with autoimmune problems. So it is very important, especially in the preconceptional period, to identify all these factors.
Right, right. So I was just messaging in my WhatsApp group that we are discussing autoimmune. Please join because we have many members who are dealing with these medical issues. So
Exactly.
one very common thing, Dr. Revati, we are nowadays getting this. Some people are saying that my killer cells are increased in levels. What exactly does it mean?
Okay, so basically, you're talking about natural killer cells. See, this is a long story. Basically, they are a kind of immune mediated cells. All right, we have two kinds of lymphocytes. We have the T lymphocytes and the B lymphocytes. And basically, this cell mediated immunity is maneuvered by the T cells. All right, so
Okay.
natural killer cells are a part of our cellular immunity. Now, what happens is, earlier it was thought that if the natural killer cells are increased in the blood, maybe
Hmm.
they can probably let us know that there is an autoimmune component, because there is an exaggerated response in the body, which is manifested as increased levels of natural killer cells, which will probably result in rejection of the fetal allograft. But then
Right.
there was a theory which was again proposed that, the blood natural whatever natural killer cells was in the blood may not actually reflect the true what you say, the autoimmune potential, and we should probably look at it from the uterus. So they probably scratched out the uterus and then measured the natural killer cells. All right.
Oh,
But what you should understand, but later it was found that, it is not just, uh, just the natural killer cells. We'll have to find out what was the trigger which probably led to an increase in natural killer cells.
natural killer cell.
So if it has just been a temporary phenomenon, maybe an exaggerated response to infection, we have to look
Hmm.
at other parameters like the C reactive protein. We have to look at the liver functions, the kidney functions, and see what is the extent of inflammatory response. And if it settles on its own after the infection has settled, we are not worried. But if it continues to persist, then we have to investigate with other bigger tests like the anti-nuclear antibody test. Look at
Right.
specific antibodies which can complicate pregnancy, and then
Hmm.
identify the disease and then treat the root cause so that we can immunomodulate them better. So just by
Oh.
saying natural killer cells are abnormal does not
Hmm.
mean anything. All right. So we need to know the clinical history, we need to know the clinical background, we need to know everything about the individual, and then tell you what exactly this particular entity means. Okay. And we definitely require a small amount of, we cannot suppress. There are people who are deficient in natural killer cells, they will not get pregnant
Oh.
either. So you need a little bit of inflammation for pregnancy to happen. All right.
Hmm.
That is
Hmm.
what we say optimizing. We cannot say we will
Okay.
suppress all the inflammation. We have to
Right.
optimize so that the pregnancy can sustain.
Okay. And usually, when we see such cases that thyroid issues is there, or diabetic, or in general term, we can say autoimmune. So, doctor said, ki, please, you take care of yourself, you take medicines 6 months prior to the pregnancy, and during pregnancy, you have to follow the protocol. So, exactly what is this? Why we are giving such huge protocol of 5 or 6 months before conception? So, is this really to suppress the inflammation, or is this really to make body compatible for the fetus? What exactly is this?
That's a very important question you have asked, Purnima, and I'm sure this will add a lot of courage to those women who are on treatment. Uh, I'm actually sharing this experience on behalf of all my pregnant women who've got pregnant after immunomodulation. All right. So it's worth the effort. First of all, believe in it. See, if you have really been diagnosed, like for instance, Purnima actually mentioned there could be a thyroid abnormality, right? So if this thyroid, say for instance, a TSH level is say about 3.5, and we know that if you are going to conceive at this, you may not conceive with those levels, or even if you conceive, you may have problems like first trimester bleeding, first trimester abortion. So we don't want to, encourage you to get pregnant when the levels are not correct.
Hmm.
This could be independent of an autoimmune association, or it could be a part of a bigger autoimmune disease. All right. So, suppose you
Oh.
have a TSH, which is abnormal, and it also
Hmm.
has an antibody associated with it, like, for instance, this TPO antibody, which could be positive in these individuals. You have to look at whether it was part of a bigger autoimmune process. So we will evaluate for other autoimmune factors as well. So some of these women can turn positive for anti-nuclear antibody. They may have other autoimmune conditions like SLE, scleroderma, apart
Right.
from having a TPO antibody positivity and abnormal TSH. In those
Okay.
individuals, it's not enough if you only supplement them with thyroxine. All right. We
Hmm.
have to immunomodulate them with drugs like hydroxychloroquine or steroids, because it is a part of a bigger autoimmune problem, just like scleroderma or other connective tissue problems. Or it could be, an anti-nuclear antibody positivity, which requires immunomodulation. In that situation, just treating thyroxine may not be sufficient. But
Hmm.
if this individual does not have any other autoantibodies and she is only positive with TPO antibody and she has a fluctuating thyroid level, definitely you may not require other immunomodulators, but you may require more frequent surveillance. That is, if I'm looking at a
Right.
TSH every 3 months in a lady who's wanting to get pregnant, I would look at it every 6 weeks to make sure it does not fluctuate and adjust the thyroxine levels. So all
Okay.
this work requires a minimum period of 6 months, because see, all you say, pregnancy is a stress the body has to take. So the moment you
Hmm.
are pregnant, your hands are tied, you have bad levels, so you have to make sure that the woman is safe, the baby is safe, the outcome is good. So it is always better to control these levels, make sure that the woman is under remission, that means she is properly treated, and then the body becomes receptive to, for pregnancy. So this is
Right.
something that we will have to probably work for a minimum period of 6 months. But we
Six.
have seen that when we do this and the woman gets pregnant after proper immunomodulation and correction of risk factors, her pregnancy becomes very smooth. So that is what is expected.
Right. Right. And what about the medication part during pregnancy?
Yeah. So if there are two kinds of people, all right. If a woman is already, like for instance, having an autoimmune problem and she also has other metabolic problems like thyroid or abnormal thyroid function or abnormal sugars, we will make sure that all these are under control and then she gets pregnant. All right. So, what we are trying to prevent is an abnormal flare. You cannot prevent pregnancy induced changes, which can happen, which will happen.
Right.
Like, for instance, when you get
Agree.
pregnant, it is bound you are bound to have insulin resistance. That is, the body, whatever insulin is in the body, will not function the way it should function. And with
Hmm.
our race, like for instance, Indians are very prone to this insulin resistance. We will develop that kind of a problem where the sugars will get exaggerated. So, but we already know this lady has a propensity for abnormal sugars. She's been monitored for thyroid dysfunction. Her autoimmunity has been immunomodulated with drugs like hydroxychloroquine. So we will periodically check the levels of the thyroid or the blood sugar levels, adjust it. We may
Hmm.
have to top it up along with diet. This lady may require insulin if needed, or this lady may require an upgraded dose. See, for instance, the fetal thyroid develops only at 12 weeks of gestation. Till such
Okay.
time, the fetus is entirely dependent on the mother for thyroxine requirements. And why do we
Right.
need thyroxine? It is important for the neurological development of the baby.
Right.
So the supplementation, usually what we say is, if a lady is hypothyroid and she's pregnant, obviously the moment she gets pregnant, she may require an upgraded dose of thyroxine, unless and until we are completely sure that her TSH levels are optimized just before conception. So after 12 weeks, the demand will slowly come down. But till such time, we have to be very careful. And it is a myth that it is only for the fetus, it is also for the mother, because if there is abnormal thyroid function, she can have abnormal blood vessels. That is, the lining of the blood vessels may not be very good. I mean, there could be an endothelial dysfunction, which can lead to problems like hypertension, preterm birth, and those kinds of things, which can jeopardize outcomes. So, a woman who is already risk modulated goes through a surveillance plan. This clinician, like for instance, if I'm doing a preconceptional counseling, I have identified these factors. I will give her a surveillance plan every trimester. I will tell her, first
Okay.
trimester, I'm going to do these things. I'm going to look at it. I'm going
Mhm.
to anticipate these problems. But by doing this, I can definitely minimize the problems and optimize her outcomes.
Right. Agreed.
So after she
Right.
gets pregnant, these medications will not stop. They will be
Hmm.
titrated as per requirement, but it will not come like a surprise, because the clinician is already well prepared, the patient is already well prepared, and these things will continue 6 weeks post delivery. Immediately after delivery, it will not stop, because the pregnancy related changes will continue 6 weeks post delivery, up to which this lady has to remain on these medications. All right. So after that, after 6 weeks, we will again look at them and tell them what they have to do, how they have to follow up these factors for the rest of their lives.
Right, right, understood. So we can say, Dr. Revati, if we have such conditions, such issues, then we have to optimize the things before, during, and after pregnancy. So in three portions we
Absolutely.
can divide. Okay, right, right, right. And one thing more, is this condition what we call increase in killer cells, or we can say autoimmune disorders? Is this the condition is responsible for recurrent miscarriages also?
Yes, I mean, if you're talking about an exaggerated autoimmune response, which can probably lead to raised inflammatory markers, which it also includes the killer cells, I mean, because it's not a standalone entity. Yes,
Right,
it can. Because, see, what is this autoimmunity is not allowing that lady to get pregnant, or if she's got pregnant, it does not want that pregnancy to continue. Because, see, initially, when you conceive, when a woman conceives, there is no placenta which is formed. The placenta starts forming only after 8 weeks of pregnancy. All right. Till
right.
such time, this embryo, what we call the early fetus, is called an embryo up to about, say, 8 weeks. So this embryo is not protected. This has a maternal component, it has a paternal component, and the body kind of rejects it, saying it's a foreign body. So a woman
Foreign.
who has exaggerated autoimmune response wants to get it out. But this placenta is something that is forming between the mother and the fetus, which would probably condition this fetus, condition the body, and protect this embryo. Okay, and that starts only at 8 weeks, and it probably gets completed structurally only at around 14 weeks. All right.
14.
So till such time, this fetus is relatively unprotected. So definitely, if you're looking at multiple pregnancy losses, especially in the first trimester, and even growth restriction or intrauterine fetal demises, autoimmunity definitely has a role, and this has to be modulated in the background of other factors. We should not forget that a woman who is autoimmune can have a propensity for diabetes more than the general population. A woman who is autoimmune can have hypothyroidism. A woman who's polycystic ovary, who's had a PCOS kind of a situation, can have all three. All right. So we have to be alert and aware, and they may also have clotting abnormalities. So, especially in the background of recurrent pregnancy loss, we have to keep all
Mm-hmm.
this in mind and then treat them effectively.
Okay, right. And what about the test? Like, see, thyroid, we all know that we need to go for THS, T3, T4 levels, and that's it. So, what about the all other tests to see if one lady is having recurrent pregnancy losses? Obviously, we need to find out the reason that why it is happening to her again and again. We can say that chemical pregnancy or pregnancy loss at very early stages. So, what all test you would recommend for such lady to go and check whether she falls in this category or not? So, those list of tests or whatever you recommend to that lady.
Yes, Purnima. So along with your TSH, I also recommend, most of the times to do a free T4 value rather than doing a T3, T4, because if the woman is already pregnant, but in the preconceptional period, they can do a total T3, total T4, which would probably reflect what is the actual response of the TSH to the thyroxine that is actually produced in the body, because there could be situations where there is a discrepant value which requires a different kind of an adjustment. So along with that, and also measuring, I would definitely want to make sure her sugar glycemic status is normal. So we want her HbA1c, which is
Hmm.
basically a tool to measure the glycemic status of that individual, to be ideally, if I would say, if I'm looking at pregnancy, I would want it to be less than 5.5. All right. If I'm looking at normal for a non pregnant lady to be at 6, if I want the lady to get pregnant and to have a healthy pregnancy, I would want a HbA1c level of about, say, 5.5. All right. This is one. Apart from that, if you're looking at autoimmunity, if you've had a lady who's had one biochemical pregnancy loss, one first trimester pregnancy loss, and then again something like a mid trimester issue, and you don't know whether there is a background autoimmunity working, you definitely want to look at her inflammatory markers in the body along with an anti-nuclear antibody test. I don't do the natural killer cells generally because I feel
Mhm.
I should rather look at the inflammatory responses, which would be more worthwhile than just looking at natural killer cells, because doing the test itself is very expensive. So, and it would be a generic thing and not a very specific thing. So I
Okay.
usually do their C-reactive protein. I look at their liver functions. I can look at their
Mhm.
liver enzymes. I look at their, renal functions, and look at, their total count, their ESR, and also look at an anti-nuclear antibody test. So looking at this, I can
Mhm.
interpret whether if they are abnormal, there could be a there possibility of autoimmune condition. But what you should understand is, suppose somebody is positive on these and they're also positive on the anti-nuclear antibody, we have
Mhm.
to look at a set of other antibodies. Like anti-nuclear antibody just tells me that she's autoimmune, but what kind of autoimmunity? She could be, uh,
Right.
a disease like a systemic lupus erythematosus. She could be scleroderma. She could be mixed connective tissue disorder, and all these autoimmune problems usually manifest, in their mid 40s or 50s. So they don't really have symptoms sometimes. They
Mhm.
only present with difficult conceptions or recurrent pregnancy loss. So in those situations, we do specific antibody tests, like the double stranded DNA. There are a list of 10 antibodies only for those individuals who are positive on the anti-nuclear antibody. And if they are positive on that, we will have a specific treatment strategy directed to the disease per se and immunomodulate them for pregnancy. But if they are negative on all that, we only consider immunomodulation for pregnancy. But what you should understand is these are not over the counter prescriptions. You
Right.
cannot just decide on your own that you need a particular test. And also, let me tell you, there are women who are negative on these parameters, like, for instance, anti nuclear antibody, but they may have inflammatory parameters which are high, and they may have a positive clinical history. In that
Mhm.
situation, we call them the seronegative variety. That means they are not positive on the blood tests, but they have clinical problems.
They have.
And after
Right.
appropriate counseling, we still institute certain immunomodulation uh, drugs. We treat them
Okay.
for it. So this is not something that a patient or a person who is affected can do it on their own. They cannot Google it. They need to meet a clinician. They need to spend some time with the doctor, looking at what happened at every pregnancy, and then decide. The doctor is the right person who can decide, yes, these are the stress. But if I'm looking at it generally, you need to
Mhm.
look at the thyroids, you need to look thyroid functions, you need to look at the sugars, you need to look at a basic complete hemogram, you know, to look at what is happening on the head, because we've had so many women present to us with ITP, thrombocytopenia, where the platelets are low. That is again an autoimmune condition, and
Right.
they have had recurrent losses. And when I investigate them, they have other autoimmune problems. So even a simple complete hemogram may throw light on what is the problem that is probably existing. So we need to do a complete hemogram. We need to probably decide on an autoimmune profile if in case there has been losses like what I described, different kinds of losses. So this is
Right.
briefly what you should probably do.
Hmm. And it is really important to discuss the things with your doctor because, see, as you just mentioned, that Googling does not help. And we also believe that let's talk to your doctor, discuss everything, and then proceed further with the treatment plan and all that. So, Dr. Revathi, what about the male factor? We were
Yes.
discussing about female dealing with autoimmune conditions. Is it really possible that males are also dealing
Yes.
with this, or only female we can say?
See, what I would say is mostly for conception. Yeah, we've had some women, some men, where they have bad counts. And when we
Hmm.
actually look at them, they have autoimmune conditions like psoriasis, they have rheumatoid
Okay.
arthritis, they are on some kind of
Mhm.
medications. They are on statins because they have metabolic problems, like they have
Mhm.
hypertension, bad cholesterols. So I feel, and I feel so sad sometimes because, whenever there is a lady, whenever there is an appointment for preconceptional counseling, it's only the woman that comes. Okay. Because the husband never accompanies, because it's always that, you've been conceiving and he presumes that everything is all right with him, which is wrong. Because we don't know if if this lady has approached me because she's had abortions, or she's had a bad
Hmm.
obstetric outcome, or she's not conceived. There is definitely an equal responsibility of the male, because it could be bad sperms, and
Right.
bad sperms is what is manifesting as the endpoint reaction. So what happens? Why did it contribute to bad sperms? It could be a medical problem. It could
Hmm.
be diabetes, which could probably lead to bad quality sperms. It could lead to erectile dysfunction. It could lead to, and if a man already has metabolic problems like hypertension, bad cholesterols, and if he requires treatment, and if he is on disease modifiers like statins, it can reflect again on his sperm counts. And like how I told you, a man can have autoimmune problems for which he is on medications, which can again affect the sperm counts. So
Right.
I always believe, I always emphasize that whenever there is a preconceptional evaluation visit, the husband should accompany the wife, and both are equally responsible, and they have to understand this as a common unit, and try to confront this together, so that ultimately, they're going to conceive as a couple, not just the woman.
Right, right. Totally agree. And we can say that if you are planning to visit the doctor or specialist, please visit as a couple, not as an individual. And Dr. Revathi, I think we need some kind of encouragement. Uh, as a society, we usually put a special burden on the female for conception, for carrying a child, and males can obviously enjoy. And we can say that nature is somewhat biased, because we as a female have to undergo lot many tests, and male can easily one simple test, and yes, they are fine with that only. So, Dr. Revathi, next I would really want to know about hypertensions. Nowadays, stress conditions, maybe it's related to society pressure, family pressure, and obviously work. So these all pressures combined together, and we are dealing with a condition called hypertension. So if we are having these hypertension conditions before pregnancy, so could this also be the reason for a lady for not conceiving at proper time?
uh, you're talking about hypertension, or you're talking about stress?
Hypertension, we can say, on general thing.
Okay. See, what you have to understand mostly is basically, yeah, like how you said, we are identifying, in fact, not just the woman. In my preconceptional clinic, I identify a lot of men who are hypertensive
Hmm.
as well.
Right, right,
So
agree.
basically, whenever hypertension, what we call essential hypertension, where it is not related to a secondary cause, like there is, like for instance, a kidney abnormality or an adrenal gland abnormality, which is probably causing this hypertension, and this is just attributed to the stress, which is causing this kind of hypertension.
Mhm.
What I actually find in most of these women is the moment they are on medications, they assume that they will never conceive. Usually, essential hypertension does not, cause infertility kind of a situation. But what these people, either they are so stressed out because they're taking medications, they don't know how to probably plan their pregnancy. Either they conceive, because they're on certain medications. Like for instance,
Oh,
most
right,
of
right.
these women can be on medications like ACE inhibitors, which are not very good for pregnancy. So I don't want these women to conceive these medications. So if they are going to conceive with these medications, the baby can have structural defects. So what I feel is, don't get worried because you're hypertensive. Meet
Hmm.
a specialist who can probably guide you, just not for hypertension. See, hypertension in the reproductive age group women needs special care and attention, because they have not conceived, they can get pregnant, they need to manage their pregnancy, come out of it, and still be healthy for the rest of their lives. So,
Right.
we can definitely identify what is the level of hypertension. We can probably identify which is the best medication that they can be on safely, so that they can conceive with that medication and it will be smooth for us to take, because pregnancy can impose an additional stress of worsening hypertension. All right, so this can be prevented by doing the right titrations. And most of them, when they approach me, we call it what we say chronic hypertension, because they've been hypertensive for quite some time. These are usually the
Mm-hmm.
essential hypertension variety. We tell them, see, you always plan this pregnancy. Don't just randomly conceive. All right, take an opinion and find out
Mm-hmm.
about your, fertile period. Or if there is going to be an ovulation induction, which could probably help you conceive at the right time, please take help from the doctor. Manage your hypertension, conceive with the right kind of treatment, so that it would not just be, if the moment somebody talks about fertility treatment, everybody assumes it's IVF or it's an IUI. It
Right.
may not be that. All right, it is just that the doctor is trying to tell you which is the fertile period by doing some simple evaluations on scan, and tell you at what at what particular time you should probably have a timed intercourse, so that if in case pregnancy happens, we know that this lady has conceived at the right time, and give the right supports. Be on folic acid, very very important. Nowadays in India, we have problems not just about folic acid. We have a condition called hyperhomocystinemia, which is usually manifested because we are also, as Indians, we are deficient in B6, B12 and folic acid. So only
Right.
folic acid may not suffice. So we need to give them adequate amounts of B6, B12, folic acid, and then let them conceive. So all these steps, and a woman who is hypertensive may be diabetic. So we can look at those factors. We can look at thyroid abnormalities, because that could contribute to worsening hypertension. So this is the best time, like if you want to wear a beautiful dress, you would go to the tailor and say, I like this color, I want this particular pattern, I want this, and the tailor will do it for you, isn't it? In the same way, and then the beautiful dress happens. But you can't do it on your own, but you can only share your idea. So in that way, you consult a doctor like a friend. I like this term fertility Dost, it is so touching and so friendly. And you don't think that you have to meet a doctor only when you have a problem. All right, you
Right.
go and discuss your challenges. The doctor can probably work along with you and tell you how to make your journey easier. It's not only when there is a trouble that the doctor should come into picture. So if we can do
Right.
this, we can definitely make a difference to the outcomes. So
Right.
after this, these women get hypertensive, Purnima, there is a real
Mm-hmm.
challenge where we have to look at. So that is something that we have to look at. See, because there is a condition called preeclampsia, which can happen after the woman is pregnant. And this is a very serious form of hypertension, which is because the root cause is because of endothelial dysfunction. Endothelium is the lining of the blood vessel, which is not probably functioning properly. So there is a difference in the blood flow patterns, which can cause increased resistance and worsen hypertension. Earlier, people used to think only when hypertension is associated with protein in the urine, it is called preeclampsia.
Right.
But now it is not like that. It is any form of hypertension in pregnancy which can lead to adverse outcomes. So you need to find out, are there factors which can lead to preeclampsia? So you need to do predictions in the first trimester itself. You need to be on low dose aspirin, so that it can prevent the onset of this preeclampsia very early. And then there are biomarkers with which I work. I told you about this, I think, in the
Mm-hmm.
preliminary discussion, which can probably identify, they are simple blood tests, which can probably identify those women with hypertension, particularly, who can probably have adverse outcomes, where the woman can throw a fit and have eclampsia, or the baby can just succumb inside the uterus. So all these are preventable, but they need a
Right.
lot of surveillance. So you need to consult the doctor much earlier. Don't, try to have an unplanned pregnancy. That is something that I want to tell.
Right, agreed. I totally agreed, and I think the viewers, this is really important. We do planning for everything, and as Dr. Revathi mentioned, selecting a dress, even we can say that we have plannings one day before of the meal also, what we are going to have in the breakfast, lunch, dinner. Then why not have this proper planning? And as in every session we emphasize that please visit the doctor at right time. Right doctor is really important, time is really important, and please don't hesitate to discuss your concerns. Like, it may be it may seems to you that it's just a minor thing, but for your doctor it may be the very important thing to predict your conditions. So please don't hesitate, just talk about it openly. And as Dr. Revathi mentioned, visiting infertility specialist always doesn't mean that you are going with IUI and IVF. And we have seen many cases where failed IVF and natural conception. So it is possible. And Dr. Revathi, May is the mental health awareness month. So I really want to focus on this more, that stress plays an important role in your life. If possible, please you start playing with this stress. And if you need any kind of counseling, any kind of help, so please just drop a single message to Fertility Dost. Visit our website, you will find lot many articles related to this. You just join our closed Facebook group where you have a support community. You can talk, you can indulge in your inner self with other ladies who are undergoing these treatments. Dr. Revathi, one last question, and we can say that very important of the full session. When such couples undergo the IVF, the conditions they are dealing with, autoimmune, or we can say that metabolic hypertension. So, is there more risk involved when this IVF is involved with such conditions?
What I want to tell you, Purnima, IVF can be because of so many reasons.
Hmm.
Unfortunately, I have couples who come and say, Doctor, I want an IVF. I'm saying, let me decide whether you really want an IVF. Or there are women who really want to have, should have an IVF and they're just wasting time. So they've been said,
Right.
because people have really not understood. And let me tell you, IVF is not a quick way to get pregnant. It's only to be done when it is indicated. So if you have a woman who has had an IVF because her tubes are not good, she's young, or her husband's counts are not good, her risk because of IVF will not definitely increase her risk of having problems during pregnancy. Because I myself have compared IVF versus non IVF pregnancies, and the technique per se will not add any special risk of bad outcomes during pregnancy. All right. But like you know that most of the women who get pregnant because of IVF have other medical risk factors also. So they may
Hmm.
be diabetic, they may be obese, they may be elderly, they may be donor gamete conceptions where we've used a different egg from a different person. So these kinds of women are definitely prone to have problems because of the nature of risk that they inherently have. All right. It's not because of IVF. It's
Hmm.
because of the risk with which, suppose this lady, like how you said, there's a lady with several failed IVFs, and then she finally gets her metabolic factors corrected, her autoimmunity corrects, and then suddenly she conceives naturally. Now, will you say that this lady is going to be a low risk because she conceived as a natural conception? No. If
No.
she has conceived with risk factors, she needs, that is the problem. The moment you conceive naturally, even a 39-year-old decides not to visit a doctor till she is 12 weeks, which is the sad
Right.
part. So any woman who is pregnant needs to be given a step up attention, whether she's a 23-year-old, whether she's a 30-year-old, whether she's an IVF conception, she's a non IVF conception. Then we need to de risk. We need to identify what are the factors which are complicating that pregnancy. Just don't be only predisposed about the technique. Find out what are the factors which led to an IVF. Why did this lady have an IVF and get pregnant? And then identify those factors which can influence pregnancy outcomes. So, gone are those days where a woman just gets pregnant and just keeps swallowing iron and calcium and folic acid. It's much beyond that. We are looking at those babies which need to be healthy in spite of these risk factors. Why is our country considered to be a diabetic hub? That is because most of these women have really not concentrated on their babies, and these babies have grown in an in utero environment which is not congenial for them, have had maladaptations. That is why we have early onset obesity, diabetes, hypertension, stroke. So,
Right.
pregnancy is a serious uh, milestone in your lives. It involves you as well as a baby, which needs to grow as a healthy adult. So don't just get carried away that only IVF pregnancies need to be high risk. Just be open minded. IVF is just a technique which is helping you conceive in spite of these factors, but you need a proper evaluation to identify what are the factors which can probably contribute to pregnancy and undergo surveillance. Just because somebody is an IVF pregnancy, I wouldn't say that she needs to be treated. I mean, her outcomes will be different compared to a natural conception, but she has to undergo surveillance depending on what the risk factors are. So she needs to be with the right person. She cannot just be in a general clinic where these factors are not anticipated. See, once the problem occurs, it's difficult for us to reverse it. So you need to
Right.
be on a protocol where there is more anticipation, there is more surveillance, there's a lot of time spent. See, unless I sit and counsel and tell them, see, everyone is not a medical graduate. So if I'm just going to throw away some technical words, the patient will not understand. So we need to have that patience to impress what are the scientific facts so that we have an equal contribution from the patient to take responsibility about the pregnancy to make it optimized.
Right. Totally agree with this. And one question we can say that from my side, if I am a typical autoimmune candidate and I have recurrent pregnancy losses, can I opt for donor cycle for healthy pregnancy, or my donor cycle will again be impacted by my conditions?
See, Purnima, donor gamete is not a solution for recurrent pregnancy loss. Okay, you might
Okay.
have problems with the uterus, where
Hmm.
or the problems with the gamete. So, if in case by any chance a bad oocyte has also contributed to a bad embryo, which is not sustaining, there
Hmm.
maybe there is a role of donor gamete. But if there is a bad uterus, which is probably not able to carry through because of an anomaly or something else, which is probably leading to those losses, then changing the gamete will not help.
Will
So,
not.
just for recurrent pregnancy loss, changing the gamete is not the solution. All right. You have to identify what are the factors. Let me stress recurrent pregnancy loss is multifactorial. I had a lady recently, I mean, maybe a few days ago, where she approached me with a typical first trimester missed abortion. The heartbeat went away. She's been conceiving naturally. Second time, she had growth restriction, but the baby did not survive, it died. And third time, she developed hypertension, went through pregnancy, through a fit, and finally had a stillborn. So she had all kinds of losses. And when I actually looked at her case, she was a full fledged case of hyperhomocystinemia. She had
Oh.
B6, B12, folic acid deficiency. I had to correct it. She was diabetic. She did have a clotting problem. So we did all this, allowed her to conceive naturally, and finally that baby came out normally. So what I'm trying to say is IVF is not a solution for all recurrent pregnancy losses. Changing the gamete is not a solution for all pregnancy. Let us be open minded, look at all the factors, and by just looking at some literature which may not even be certified, because you get all kinds of literature which is available on the internet, you cannot decide for yourself what is best for you. All right, you need a qualified professional, a practitioner who can probably take onus of what decisions are made. And yes, like how you said, it requires a lot of support mechanisms. In fact, I'm trying to develop my own support groups. Like if a woman is had these problems and she's conceived, she can talk to another lady, confidentially, and say, I did it
Right.
and you can do it too. So this requires a comprehensive evaluation and treatment in a specialized setup. In fact, I advocate early pregnancy clinics who can do this starting from the preconceptional period. You need to have specialists who are just not looking at pregnancy, who can also do a little bit of immunology, a little bit of endocrinology. There is where the role of maternal fetal medicine is. This is a new discipline which is probably taken
Mhm.
off, and we want to advocate this and make it, more. What do you say? More. And known to all people across the country. In fact, I'm the secretary for the Society for Maternal Fetal Medicine India. The whole idea of doing maternal fetal medicine is to identify risk factors, down regulate these factors, optimize the outcomes, avoid criticality. I don't want any woman to die or a baby to die because we have not looked at the risk factors early. That is our motive. We want every pregnancy to be safe and planned and optimized.
Right. This is so beautiful. Seriously, this is so nice. I could say that encouraging words, and I'm touched by this whole. And the last parting line is really great. We really want such doctors, such societies. We are dealing with lot, because I can say that it's a real difficult journey. I too had my 10 years of infertility journey, which I never prefer to call infertility. I always prefer to call it fertility journey, because I don't want any woman
Exactly.
to say that I am infertile. No, I am fertile, and when I am undergoing this thing, I am undergoing my fertility journey. So I really want, and we really want such doctors, such associations, such people. Please come out. Society is there for you. We need really help. uh, we have many women who are dealing with this, and they just don't have courage to come up and talk about it. And Dr. Revati, at times we the questions I am asking, people are even hesitant to post their queries on social media. They always send anonymous queries to us personally, and they tell us to, ma'am, please ask it. So this is the kind of society we are living it. We don't want that hush hush thing. We want you to please talk about it. At least talk, discuss. And I prefer ki, if you just don't want to post your queries, at least listen to the session. And viewers, I would again emphasize, please watch this session from the beginning. We have discussed very important topic. And if you have anyone dealing with this condition, and please don't call it infertility, we all are fertile women. So please tell them to get connected with us. Tell them to you can just share this link with your known one. Just tell them to watch this and know the factors associated with pregnancy. It's pregnancy, late pregnancy always doesn't mean IUI or IVF. Natural conception is still happening. And with this parting note, thank you, Dr. Revathi. Thank you so much for giving us your time. It's almost an hour, and we are really touched with your nice, encouraging words. Thank you, Doctor. Thank you.
Purnima, thank you so much. And I felt really moved about your journey as well. And I think this is a very nice platform. I liked the entire concept. I liked your moderation. I liked the name Fertility Dost. And I'm sure you've asked those questions which are already always, troubling so many women who've never asked. So if
Right.
we can make a difference even to a single lady who's had this problem, who's listened to this program, I think we have really achieved our goal. And I'm sure you will continue to do this. And I am welcome to any suggestions which probably can lead to good optimized outcomes. So stay safe, stay healthy, and don't probably take pregnancy as chance. Make it by choice and make it a very, very happy and a successful journey.
Bilkul. Right. Thank you, Doctor. Thank you.
Sure. Bye.